everyone hear me okay? Yep. Okay, thank you. I wanted to face the full audience here. So I'm Beth Darnall. I am a clinical professor at Stanford University, and my doctoral degree is in clinical psychology. I do not prescribe opioids. I have deep ties to the state of Oregon. I was an associate professor at Oregon Health and Science University for 6 years before I left for Stanford University. I was the president of the Pain Society of Oregon in 2012, just before departing for California. I have written multiple books on this topic of opioid reduction. And the reason I became interested in it was in treating individuals with chronic pain who specifically sought me out because they had an interest in opioid reduction. And so I sort of crafted my career around really tailoring my work to meet the needs of this segment of the population. So I give you this background to let you know that I've been an advocate for all patients in terms of just learning the right information so that they could need and use as little opioid medication as possible. However, I strongly believe in preserving prescriber autonomy in cases where there is clear benefit for opioids. I'm also the principal investigator for the EMPOWER study. This is effective management of pain and opioid-free ways to enhance relief. This is a national pragmatic study on opioid tapering that's being conducted in 4 Western states. We are studying 1,400 patients taking long-term prescription opioids. And I will describe this to you in detail, but I come before you to present this study and some methods about it because it most directly applies to the patient population under consideration, because this is a pragmatic study. And what that means is that we literally go into primary care and pain clinics and we alter clinical care, and then we study the results of that. Today, however, I am focusing my brief time very narrowly on this topic of what is under consideration, which is mandated opioid tapering. And my understanding is that the proposal is for this tapering to go to 0, but I'm really focusing on mandated opioid tapering. And so I came here to review the evidence with all of you and also to offer an option to address the current needs for best practices in patient care, individuals who are living with chronic pain who are taking long-term prescription opioids. The fundamental issue is that patients taking long-term prescription opioids for many years and even decades require different considerations and care pathways than other patients for whom they may not be taking opioids, or maybe they've just been taking them short term. So the issue at hand really focuses on patients who've been taking opioids long term, what I sort of call legacy prescriptions. The evidence to date is limited because it does not directly apply to the current population under consideration for these mandated tapers. And I just want to review a couple of...
Unplugged over here. On the ground, behind you. Okay, you're on.
Hello? Hello, hi. So I just want to review some of the evidence that it's been uploaded and sort of more speaking to the benefits or efficacy of opioids, but I want to describe why these guidelines and why these studies are ill-equipped to actually inform anything about opioid tapering. So the first is the SPACE trial, and this is often quoted and cited, and it's an excellent study. I know Dr. Krebs, she's an amazing researcher, very well respected, but the issue is that it's a prospective study of de novo opioid prescribing. It does not inform best practices for opioid tapering at all, because that was not the focus of their study. The CDC Guidelines, 2016, everyone is very well aware of the CDC Guidelines. They report considerations for new prescriptions. They recommend close monitoring of new prescriptions and also discontinuation in cases where where that monitoring is revealing that the opioids are not benefiting the patient. The CDC guidelines offer no guidance for best practices in tapering legacy prescriptions and addressing the needs of this specific segment of our patient population. There was a study that was uploaded. It's Frank et al. This is a meta-analysis of multiple different studies that looked at opioid tapering. The issue with the Frank study is that when you take a look at all of the studies that they included in the meta-analysis, there's a wide variability in the methods that the studies used. And in fact, only a few of those studies focus on patients going to zero opioid dose. And of those studies, they really don't apply to the Oregon Medicaid population. And the reason is that they received services that are really not widely available here, such as intensive inpatient rehabilitation, Suboxone support, and what is called sort of chemical detoxing. These services are not available. It's not directly applicable. None of the outpatient studies went to zero opioid dose. In fact, when you look at the outpatient studies that are most applicable to the Oregon Medicaid population, those patients reduced their opioid dose by 40%. And that's when they received behavioral support, such as the cognitive behavioral therapy and other treatments. So again, these data suggesting that the current proposal are too aggressive. If we want to reference the evidence base, it does not support it. Lastly, my study conducted by my group, Darnall et al., this was published in JAMA Internal Medicine earlier this year. This study was conducted in patients who wished to reduce their opioid dose. And so this is a voluntary study, and all of my methods are focusing on patients who wish to reduce their opioid dose. Now, we recognize that sometimes this term voluntary is elusive because physicians in the community may be essentially saying, look, I need you to reduce your opioid dose, or this is the guideline. But when they come to us, we're not forcing them to do anything, in fact. We provide them with a safe and compassionate structure so that they feel secure in being willing to try to reduce their opioid dose. All of our methods are focusing on partnering with the patients and helping them feel as much control as possible in this process in which, again, they have agreed to partner. So if individuals wish to pause the taper, if they need to move at a slower pace, or if they wish to stop the taper altogether, we do not force them down any particular care pathway. Our goal is to nurture them forward to the lowest comfortable dose for each individual person. Now, when you take a look at our JAMA Internal Medicine study, on average, individuals reduced their opioid dose by 50% over 4 months. But here's the thing, there was wide variability. A few patients increased their opioid dose. Some patients did go to zero in 4 months. But the point is that our program and the outcomes were individual. And this underscores the importance of having clear flexibility in programs and policies so that we're best treating each individual's patient's needs. Now, you may ask me, how did you get patients to volunteer to reduce their opioids? Well, the truth is there is a segment of patients who wish to reduce their opioids, but they've never been offered a compassionate pathway to do so. Others may have heard about the risks of opioids and they want to reduce them, but again, they don't know how. We discuss with our patients the potential benefits and we emphasize close support and care. We're actually offering them better pain care because we're monitoring them so closely and in a way that they have never received before in traditional pain care pathways. So finally, I just wanted to present some consensus data from the Veterans Administration. So this is through the VA system. And the latest consensus that was put forward by Freedom Sandbrink, and he is the acting director of the National VA Healthcare System. He states strong caution for involuntary tapers as they carry significantly greater risk than voluntary tapers. They interfere with collaborative provider-patient relationships and the shared decision-making models that we know help our patients achieve best outcomes. Medical and psychological destabilization can occur in forced opioid tapering, leading to patient distress and other harms. Increased suicides are reported, and these are even at relatively lower doses. There's a false perception that opioid overdoses, and in particular suicide risk, increases with the higher doses. The data from the VA are showing that 80% of suicide decedents had opioid doses below the CDC recommended threshold, suggesting, again, that lower opioid doses do not confer a degree of safety, that it's this destabilization in the process that is one of the greatest risks at hand. Medicaid recipients may have even greater vulnerability due to lower socioeconomic status, fewer resources, greater medical complexity, and greater mental health needs. The Empower study is funded by the Patient-Centered Outcomes Research Institute. I mentioned to you that this is active in 4 Western states. This is voluntary, patient-centered opioid tapering program. A key component of the Empower study is that we train prescribers, physicians, nurses, physicians' assistants, how to implement our methods that are patient-centered and, again, focused on helping craft an individual taper program that maximizes patients' sense of control and actual control in the process. Once patients enroll, we track them closely. We deploy surveys to them weekly to understand their response to the taper, to ascertain whether they're having difficulties, whether they're experiencing any withdrawal symptoms or anything else that we need to triage. We offer them close clinic follow-up if needed. Of these 900 patients who will be agreeing to reduce their opioids, we're randomizing them to one of 3 groups. One group is 8 weeks of group cognitive behavioral therapy for pain, so that's led with a psychologist. Another third of our patients will receive 6 weeks of peer-led chronic pain self-management program, and the other third of our Empower patients just receive our patient-centered taper only. Because there's a lack of data on how to best reduce opioids, our study, the Empower study, is designed to collect these information to inform best practices for safe and humane care. Once we have these information, we will inform pain care nationally. I mentioned that the Empower study is in 4 states, and we're studying almost 1,400 patients in total. I can offer you this program for Oregon if you wish to carefully study a group of Medicaid patients who wish to voluntarily reduce their opioids. I'm willing to share the information with you without any fee for my time. This is an opportunity to collect your own evidence about how to best help a select group of Oregonians, those on legacy opioid prescriptions who require special care pathways and for whom no evidence exists, direct evidence for tapering, but evidence does suggest risk for harms. I applaud the board for placing attention on the fact that society is at risk and measures must be taken. I'm advocating for this specific segment of the Medicaid population, patients taking legacy opioid prescriptions. These patients are underserved and have complex care needs. Evidence is lacking for forced tapering, and no outpatient studies exist for a 0-dose mandate. To avoid risk risks and harms, careful and patient-centered approaches that study the issue in voluntary tapering could help inform your decisions in creating effective policies that are rooted in best practices for pain management. Thank you. Sorry, I won't yell at you. The Empower study is 12 months. So our patient-centered taper goes for 12 months, and we do not mandate zero opioids. It's open-ended. We basically partner with patients, and we tell them we're going to help you get to your lowest comfortable dose over 1 year. We're hoping that people reduce by at least 50% over a year, and our previous methods suggest that that may be achievable. But we actually don't know. The evidence doesn't exist, and so that's what we aim to collect.
Any more questions from the members, please?
Yeah, Kim.
Thank you for your rigorous and compassionate approach to this problem with your work. My question is, this is such a powerful presentation, and this legacy issue is not well articulated in the literature. So my question is,
Correct.
have you published essentially what you've just told us in an editorial or a review paper?
Yeah. Okay, so that's a great question. The best evidence right now in this legacy population is really my study, but again, it doesn't directly apply because it was a voluntary study. So my evidence informs how to best taper when patients are on board. How do we do that best? But in terms of your point, is there an editorial on this topic? I actually submitted one to JAMA Internal Medicine last week. It was not accepted in the medical journal, but I have crafted a letter specifically on this issue of the risks associated with forced tapering and specifically very aggressive tapers. And we are getting sign-on from major national agencies, international pain groups, multiple individuals, and we'll be circulating that. I'm here speaking to the board and really advocating for careful and compassionate measures. This also needs to be put forward for other states and other boards as well, because there is a poor appreciation for what's at stake. And I recognize that people are trying to bring forward solutions, and the intention of that is, it's well intended, but there are unintended consequences that need to be appreciated, and methods matter. Yeah.
So, Nora, I'll get to you in just 1 second. I just had just a data question. So McPherson, they published this year the VA study where they looked at mandatory and voluntary and mandatory tapers to zero, and they found good results. So do you have any comments on that?
There has been secondary data analysis on the VA data that has really brought forward, I was mentioning the director of the VA has put forward new data describing the risks that are not well appreciated at the sort of the aggregated level. So this is the problem with research, is that when we just look at means and averages and odds ratios, we miss the edge conditions or the tails where people are really suffering. And this is what we need to appreciate, and we need to put measures in place to protect these vulnerable patients. So it's really taking a look at the individual, because opioid tapering is certainly right for some patients, but it's not right for everyone. So I was just really convinced when the director of the VA said we're seeing increased risks in these patient populations, both for harms and also increased suicides, and this must be taken very seriously.
Thank you so much, Dr. Darnall, for coming up here and presenting such a stunning compilation of information. Very useful.
Thanks, Nora.
I have specific questions, since this is a body that is working to establish policy.
Yeah.
you may not be able to answer this right now, and we would welcome your input later. But if you can give specific recommendations, in particular, what your guidelines would be for defining a legacy patient. And
Yes.
Because I think that's probably critical, and also
Sure.
recommendations that you might have in communities where there is an absence of appropriate non-pharmacological care or an absence of adequate non-pharmacological care.
Yeah, and I'd be happy to. I don't know how much time I have to answer questions. But I would be happy to answer those questions. I can even put that in something of a report for the board if you would like. We have taken all of these considerations into account in our own study methods, and I feel that your request for information is very doable, and I'd be pleased to put that together for you. I think, one of the things that's not appreciated in the United States is that almost 18 million Americans are taking long-term prescription opioids now, and this really requires special considerations. It's really distinct from whether or not we should start opioids or continue opioids after surgery. This is a particular segment of the population, and we really need to be very thoughtful and careful, and I would be honored to be even part of the solution or just providing information to you that would be useful. Yeah.
I think that'd be appreciated. Thank you.
Is this thing on? Okay, good. Yeah, thank you for your presentation. I really appreciate it. I do want to point out a couple things.
Yeah.
Number one, the legacy patients, which I don't particularly enjoy that term.
Yeah.
We did this to them. So we can never forget that these prescribing habits, we did.
Yeah.
And we've created this problem. On the second part about this, though, is absolutely we need to, I'm a firm believer in making things as patient-centered as we can. How do we implement that on a system-wide benefit when we know that there are known associated harm with these medications? Now, what has been kind of absent in a lot of this discussion is what does chronic opioid therapy do to the brain? And when we start looking at that neurophysiology, what we see overlap with suicidality, we see overlap with other mental health disorders, we have overlap with worsening pain as well. So this is, I just want to point out that this is a huge issue. Yeah. That these opioids are all kind of tied into there.
Yeah, absolutely. And, indisputably, lower doses are safer. But when we talk about mandating a taper and really going forward without having careful and thoughtful methods, by imposing that, we risk the gravest harm by destabilizing individuals, both medically and psychologically. And that is the inflection point that must be addressed.
And I absolutely and 100% agree with that. And that was one of the reasons the top recommendation that we had in this task force, for which had gotten no press at all, was pain education. Yeah. Because there is rampant misinformation, there's rampant misunderstanding, there's rampant misconceptions when it comes to pain and drugs and all these other therapies, and that I think is one of the intentions that we are hoping to address in the future. Yeah. Because when you start looking at this stuff and you realize that where these drugs work in the brain, and every drug that we take works on a natural receptor, and we start realizing that those endogenous opioid systems are working on things like not only pain, but stress management, reward and motivation systems that are affecting other organ systems in their body. If we can incorporate that into good pain education, where you get providers to understand what this works with their patients, when you have people in the audience understanding what these drugs are doing long-term to you, lo and behold, then everybody's in agreement and on a path that we can move towards forward. I mean, it's very, very difficult to do on a public policy standpoint when we're in these little task force things and you have to put on one-page statement. But I do appreciate that, and I absolutely, how can we implement this? I'm going to speak briefly to the audience members here. If you guys understood as well about how all this stuff worked together, I guarantee most of it. How many people love being on opioids? How many people enjoy being on these drugs? How many, that's it, right?
Amen.
Well, I'm going to say, we perceive we don't have a choice because we don't understand the issues enough. So I just want to put that
No. Excuse me. No.
Okay.
Excuse me. You are making a derogatory and didactic statement, assuming that these people who are living with chronic pain and who are doing everything in their power to try and maintain their quality of life stay alive, and deal with the external stressors, including the possibility of removing their education.
We went through
I'm sorry, sir. You owe these people an apology.
You know, and I apologize. I apologize because that is not what my perception is.
We are all
I am
aware.
not, what I am trying to say here is there is a whole bunch of misconceptions when it comes to pain and pain science. I'm speaking,
There are.
and I'm telling you from somebody who's a fellowship trained pain specialist.
I appreciate that.
Okay.
There are a lot of misconceptions, including on the part of the ladies and gentlemen of this committee and prescribers in general. However, when we decide to come together and stop accusing each other and stop associating addicts, people who are dealing with substance abuse issues, with patients who are legitimately trying to seek release and management of their pain, then we can move together. Yes, nobody wants to be on opiates.
Now,
yes, we are aware of the contraindications. And yes, we are trying to find a way to live our lives pain-free.
And I appreciate that, and I do not mean to insult you in any way. And I certainly don't want to derail, I don't want to derail the conversation here because, well, I know I'm really good at that, huh?
I'm going to please ask, we have public testimony in about 10 minutes. There's a few other items that I need to make sure that the task force has some input on. Thank you so much, Dr. Darnall. I really appreciate that you coming out here and your input. So there's a couple of other items. We have about 10 minutes, and I want to just briefly get through these before we have our public give us some feedback. The first is that we have asked the Center for Evidence-Based Policy to do a systematic review on the effectiveness and harms on opioid tapers. They actually had a previous review which had partially looked at the questions that we're answering. This was published last year. We're asking them to update that and kind of specifically concentrate on our more specific questions. So in your packet, you had the PICO, the key questions, that whole, and I don't know if you've had a chance to review those. I want
the page number.
Kat, do you have a page number?
If it's the public packet, it's page 69 of 92 of the PDF.
So what staff would like from you all, if you have any input into, these are the questions that staff came up with working with the med group, but obviously we want to know if these actually address what you want. So the PICO means population intervention, comparators, and outcomes. The population we're asking for is adults who use opioids for 6 months or longer for non-cancer pain. The intervention would be an opioid taper or discontinuation of opioid treatment. The comparators would be no taper, different opioid discontinuation or tapering strategies, no comparison. So there are various things that we could have as comparators or have all. What we have asked to look for outcomes would be successful discontinuation, dose reduction, self-reported pain, quality of life, function, mortality. This would include accidental overdoses, suicide, any other cause.